here again, sort of the idea about how are we going to cure myeloma, which is starting to come onto the radar. You have your induction therapy to debulk the disease, and then you have consolidation to try and knock it down as far as you can and prevent this tendency for the disease to relapse after the pressure of chemo is released. And maintenance therapy is designed to try and knock out that residual disease. We're dealing down here with very low level numbers of cells that we really struggle to detect. Maintenance therapy's job is to really try and mop it up until we cure it here, as opposed to relapsing. Certainly there's major financial constraints. The drugs cost thousands of dollars. And there's a desire, I think, for us not to embark on maintenance therapy, because the longer people survive, the more it costs. That's kind of cynical, but it is probably a factor. And they are pretty fair. Like, I think Australia's health system is one of the best in the world. And also, we see the same issue in the UK, for example, where they have to rationalise what drugs are the population going to pay for. It's a big problem, and they have a league table almost where they can measure drugs' benefit versus its cost. And if you don't make the cut, then you just don't get on, which is a reasonable way to approach cancer therapeutics. But sometimes the evidence takes years to amass before we can demonstrate, we really should be using maintenance, or we should be pushing harder. And that's probably where the drugs take a bit longer to get in here, but they will eventually come. So there's a lot of drugs presented at ASH which will be superior to Velcade, for example, or even Revlimid. And they're just going to take a little while to get in, but they'll be present in trials initially, and then they'll gradually filter into the system. Yeah, you can, if you remain sort of aware of new therapeutics that are coming out, then you can sort of, there are submissions before the PPAC where they decide whether a drug is going to be granted access to the PBS. So patients can lobby their members of parliament or directly into that process, arguing for acceptance of this drug. For example, an interesting example is bendamustine, which is a drug in Eastern Europe for many years, which we used to treat lymphoma. And it seems to be broadly equivalent to CHOP, which is a multi-agent regimen, which we always use for B-cell lymphomas. And it would be great for patients to have access to it. But the PPAC assesses how much does this drug company want for it, what's the additional benefit it's going to offer, should we really be bringing it in at this cost to the taxpayer at this time? So it's a very difficult process, very hard decisions that have to be made, and generally it's quite fair in this country. But for patients who are wanting new options, new therapeutic opportunities, and doctors who want to give it to them, I think it's just an ongoing struggle that we're all engaged in. And we obviously are on the side, we'd like as many weapons as we can in the war chest, but it is a gradual process simply because of the economics involved. And I think also drug companies need to accept that they have a part to play. We want the best deal for the taxpayer as well. It's very much the process that the UK adopts. They either force competition between drug companies, or they establish a league table so it's very transparent, so that they know what they have to do to get onto to get into the system. I mean, New Zealand has an even more vicious process where they'll just tender it and say we're only going to have one class of drug, say even for antibiotics, for example, and other ones are excluded. So they've got a fairly vicious process there, which has its implications later on for what trials are run in New Zealand. So will the patients actually get access to some of those newer agents? So there's a lot of knock-on effects and problems. But I think overall Australia is doing a great job. And if you're an American, you've got good health insurance, you're sitting pretty well. But I mean, a lot of Americans can't access these kinds of drugs either. So these are some of the sort of highlights of ASH. They were moving the definition of symptomatic myeloma. It used to be that you had to have more than 10% of plasma cells, a significant M protein, and either high calcium, kidney failure, anemia, or bone lesions. But now, if your plasma cells are more than 60%, then you get to be called symptomatic straight away. Or if you've got a lot of abnormal light chain, and the ratio being greater than 100, so say your kappa light chains were 200 and your lambdas were 2, you'd have a ratio of greater than 100, you'd be called symptomatic. If you do a whole body MRI and you just had one focal lesion, you'd be called symptomatic and you could start treatment. So there's a drift in their minds to start wanting to treat earlier. And what we're really trying to say is, well, which patients should we start treating earlier because they're at risk of progressing earlier? That's what the ones we're trying to pick up. And we find that there's evidence on PET-CT scan that a PET-CT is when you not only do a CT of the body, you also inject a tracer into the person, and that tracer goes to where the disease is most avid. So you can get pictures, which I'll show you, which show where the myeloma is. if you've got PET-CT avid lesions, your risk of progressing to symptomatic myeloma within 2 years is roughly double if you're negative. And if your serum protein is taking off in a particularly quick manner, then you're also going to progress quickly as well. Now, you all know that X-rays aren't that sensitive, but we still use them. They don't sort of really distinguish between osteoporosis vertebral fractures or myeloma fractures. You only become a lytic lesion on an X-ray if you've lost a fairly large proportion of the trabecular bone substance, and it doesn't pick up small lytic lesions. Whereas you can use particular forms of CT scans, which are relatively low dose, which pick up lesions more sensitively, or you can use PET-CT scans where you can see here the tracer goes where there's a particularly aggressively growing plasmacytoma. And after you've treated them, that area may disappear. Or here in the bone, in the vertebrae, that's an active lesion of myeloma that's resolved. Interestingly as well, there's diffusion-weighted MRI. I'm not too sure if this is offered in Brisbane, I'll have to ask. But apparently it just requires a different kind of software to detect these kinds of patterns of myeloma. And you can see the difference here between treatment, before and after treatment. And also, if you've got what a normal chest X-ray might look like, but the kind of disease that might actually be lurking there can be quite profound. So this is something that we should really be trying to get onto as well. We sometimes have those patients that don't secrete a paraprotein, so we really need to know, well, what's the disease doing? If we've got something like this, we can just follow them with imaging as opposed to just trying to follow the protein. Now, this was a provocative study. What we call high-risk smoldering myeloma. The Spanish gave those patients that are considered eligible lenalidomide, and they just observed the others. It's sort of a bit of a no-brainer. You know that one side's going to do better than the other. But what was surprising was that there was a big difference in overall survival. I'm not too sure, why waiting led to this kind of drop in overall survival, but maybe allowing the disease to progress longer led to other comorbidities and problems for these patients that when they finally did come to treatment, they did worse. So that's fairly striking as an argument to saying, well, maybe we should be starting to treat patients earlier, because the mantra has always been, just wait off until it's causing problems. And in this trial, which the Spanish are planning to do, they're going to treat patients early again with carfilzomib, Revlimid and Dex, which is an aggressive regimen, and then lenalidomide maintenance. So they're really trying to push out and see, well, what can we achieve if we start treating our patients earlier? With a little pilot group, they showed that this was a very aggressive and sensitive response. They got all patients into what they call MRD negativity by flow cytometry, sequencing of the plasma cells, and also radiologically on PET-CT. So it shows a lot of promise. This is one that will be watched closely, because if we, if we were getting great results, we would start, treating patients earlier. Now, a flow cytometer is when you put a whole lot of cells through a machine and you can look at their surface markers, see if they're abnormal or not. Now, surface markers might be CD19 or CD15. They're just proteins on the surface of the plasma cell. You can pick up a population of myelomatous plasma cells and follow them over time as they disappear. And that's more sensitive than doing serial bone marrow biopsies, because you'll see whether the disease is there. At a more, the flow cytometer can count thousands of cells as opposed to, just counting 500 down a microscope. So down to the level of being able to pick up an abnormal cell of 1 in 10,000, so a lot more sensitive. It's been shown in British trials that if you're MRD negative by flow cytometry, you do better. So it's just assessing for a deeper level of response. Sorry?
Is it much here?
I don't think anyone's doing it here, no.
No. Is it expensive?
You just need to have like a dedicated group that are prepared to count enough cells. Yeah. And you need to have good quality aspirates. So when you're looking for MRD, you're not really doing diagnostic flow where you don't count quite as many cells. You've got to count a whole lot of cells to be sure that you're really getting a good sample size. Nobody's doing that in private labs, and I don't think the public labs are doing it. Yeah, we really need to match up imaging with the bone marrow biopsy or the protein level. But disappearance of the protein level is only going to take you so far. It's really a question of, if you're going to do that degree of assessment for residual disease, you've really got to be committing yourself to doing something about it, which is having the agents or having the drug available to push for a better response. And as you know, the Americans have a bit of a shock and awe approach, not just to war, but to medicine. So they just, there are groups where they just keep on applying as much drug pressure to the disease as possible, but they've got the capacity to see whether or not they're getting benefits as well, which is something we don't necessarily have available to us right now. As always, one of the issues is should you use all your bullets up front, or should you sort of string them out, and how intensive, are they going to be selective enough for your patient to tolerate it? But usually as the drugs become more selective, more tolerable, and you get a broader range of agents, you'll be able to prosecute that kind of approach. If you've got the ability to assess, is the myeloma really coming under better and better control? Can we see which genes are going to indicate to us that the clone is shifting, that it's relapsing? All of those tools are going to make a difference. It's just going to take a while for the work to be done. So the newly diagnosed, carfilzomib was a very popular proteasome inhibitor, and there was a dose escalation study in younger patients which was starting to show great levels of response. So carfilzomib with, I think, thal and small dex, so 20 milligrams weekly. So after induction, they were 63%. And then after transplant, 73%, having a VGPR or a CR. And then if they kept going with more consolidation, they're getting up to 86% high-level responses. And you could they were just seeing how far could they push the dose. And got similar results at another centre with, after induction, 50% of patients achieving better than a very good partial response. We've got Xrays, which is this one. We've got that in a maintenance trial after you've had a transplant, which is an oral form of Velcade. Not good for ICON, but good for the patient. They don't come to day hospital. But the exciting thing about this is that all your myeloma therapy can be intensive, and yet all by mouth. You don't need to come in and get your ports, and So just starting to show that there are high rates of CR, and particularly if you're able to keep pushing on during maintenance phases, you just continue to get a better response. So the evidence is amassing that if you keep pushing with these selective agents, you do get better responses. And the regimen was well tolerated. You don't get the same degree of peripheral neuropathy that you get with Velcade. But Velcade's been a major advance. I'm going to skip through the first trial. And in the refractory setting, pomalidomide and dexamethasone. So pomalidomide's available now, coming in with compassionate supply. This was a trial with patients that were heavily pre-treated, and they showed that pomalidomide and low-dose dexamethasone was better than high-dose dexamethasone by itself. Relatively modest kind of outcomes. So median progression-free survival of 4 months versus 2 months, but basically a doubling of your survivorship with that drug. And I just wanted to give you an appreciation of what the proteasome is, because it's an important organelle in your cell. I mean, your cells are just full of machinery, and you turn over your proteins quite a lot every day, even inside a cell. And the proteasome is the structure which is a bit like an incinerator in your sink. You put the gunk in, it gets chewed up and spat out the bottom. It's where the proteins get degraded and then recycled. However, if you block your proteasome, you can imagine that all of the proteins that you're trying to degrade, they build up in the cell and they become toxic. So the Velcades, the carfilzomibs and the Xrays, they all interfere with the functioning of the proteasome, leading to cell toxicity that way. This was a well-received trial, very big numbers, reasonably pre-treated, of carfilzomib, Revlimid and dexamethasone versus Revlimid and dexamethasone. And fairly impressive additional results in terms of the overall response rates were higher in the carfilzomib group. Higher CR rates, so 31% in previously treated patients is excellent. And overall survival rates at 2 years are 73%, so this one got the big thumbs up. Well tolerated again. So the additional toxicity of carfilzomib didn't lead to any increased rates of discontinuation versus Revlimid and dexamethasone. And there were a few other selected trials of just oral therapy with, again, ixazomib and oprozomib, which we probably skip over. And some work with novel agents. So ibrutinib, which we use in lymphoma, people are trying to use that. And also some of these molecules which are involved with apoptosis. So the other big story was the emergence of monoclonal antibodies. Now, You may have heard of MabThera, which revolutionised B-cell lymphoma management, basically gave a 10% boost in the overall survival. And we've been looking for the same thing in myeloma. We needed a valid target, which has become the CD38 molecule. And you can kill the cell basically in three ways. Either the antibody binds to the cell and an effector cell comes along, recognises the bound antibody and kills the cell. Complement protein will be activated by the bound antibody and kill the cell. Or else the antibody itself will send a signal to the myeloma cell that kills it. Now the two main ones which I think are coming through is daratumumab, which targets CD38, and the ilotuzumab, which I've got on the next slide. So daratumumab, that's a very busy slide, but it's directed against CD38. They showed a two-part study, small numbers of patients, but they were using escalating doses. And then in the second part of the study, they had an established dose, I think. Yeah, part 2, an established dose for 8 weeks, twice a month, 60 milligrams per kilogram. These patients were also on Revlimid and dexamethasone. They'd been pretty heavily pre-treated as well. 90% had Velcade, 80% had had thalidomide or Revlimid, and then most had had transplants. There weren't really any serious side effects, but relatively minor things, but very good response rates, 100%, 87%. As a single agent, it achieved an excellent response rate here. Hard to understand why that wasn't repeated in the second part, but this is basically probably one of the next big steps forward in myeloma care. Elotuzumab is a little bit different in that when it binds, it leads to another cell doing its business and killing the myeloma cell, but that's also coming through. And same kind of efficacy rates, 11 out of 36, roughly a third of patients get a complete response, so very effective drug and well tolerated. I want to show that those long-term outcomes from Total Therapy 2, which was Bart Barloghi's group in Arkansas. You can see here that going out to sort of 10, 15 years, he does have, a relative flattening out of his curves. So there is an implication that Bart is pursuing that, there are patients getting cured by his therapy. So we think cure is possible in some patients. We think blocks of induction, consolidation and maintenance treatment are all necessary, and they've shown to deepen the level of the response. But we need drugs with different modes of action to exert multiple sort of selective pressures on the clone, stop it escaping. And you need to be able to get into CR and maintain it, but also be able to assess your CR to as deep a level as possible to know whether or not you're being effective. There are a lot of new drugs coming down the pipeline, but it's harder to see whether those drugs are doing anything in the standard risk patients because they'll do pretty well up front. So these drugs tend to get used initially in the relapse refractory setting before they get brought through. That's what I thought. We should probably stop there, and I'd be happy to take any questions if you like. So lenalidomide is a great drug for maintenance, and we often, if a patient's had a transplant in the past, we often try and get it into the regimen before the next transplant so that we can use it in maintenance. So you want me going for transplants? No. But if you can get the... Yeah. So it's very effective as maintenance, and you try and get the dose down to the most tolerable level because it does suppress the marrow function. And if the clone, which is making that small level of paraprotein, is not doing anything, then there's not really considered to be a major benefit in having up on these higher doses, which are, you kind of get down to a plateau phase where you realise, well, even on the high doses that we were on before, we couldn't suppress your protein anymore. We might as well get you off the more toxic levels of the drug and just observe, but keep you on something. Who get phenomenal responses even to an autograft and might go another 8 years before they have to have another line of therapy, and yet we get other patients who are relapsing after 6 months, and it's frustrating for a clinician because sometimes the protein doesn't even reveal the relapse coming. It might just turn up in the bones as a plasmacytoma or as in the soft tissues, and that means that our ability to predict that is not great for patients. So we need to have more sensitive methods for stratifying the risk at different stages. You can't just stratify someone at the beginning and assume that that's the way they're going to behave. We need to have the capacity to, over time, see what kind of changes are occurring in the clones. But that kind of sequencing effort is pretty massive, and it's not going to come around in a hurry. It probably needs the cost of the sequencing to drop a lot, and our ability to understand the information that's generated to come through. But all of those efforts are underway. It's just yeah. So Symptomatic is the agent we use to disrupt the osteoclast behaviour in the niche there, where the plasma cells are in relationship with the osteoclasts, and it also seems to have an anti-myeloma effect in its own right. And we tend to use it while there's active disease. We're trying to debulk the disease down, but then once we've got good disease control, we try and back off the Symptomatic, so that because it does have a hardening effect on the bones, if you like. So we try and reduce the frequency of the Symptomatic use. And some people, we would continue it. Often at PA, we'd continue it for roughly a year or so, and then try and back off the frequency. Yeah, so it reduces there's a natural turnover in your skeleton where the osteoclasts and the osteoblasts exist in an equilibrium. By suppressing the osteoclastic activity, you may tend to get more chalkier, harder bones over time, and with bisphosphonates you can get particular fractures, sometimes of the hips in particular, or the femoral necks, and that seems to be a particular region of vulnerability. So I think that's one of the reasons why, if your disease is well controlled, you can reduce the frequency of the Symptomatic. Well, thank you very much for listening. It was hard going, I know, but you did great. Thank you.